Hello, my name is Hyma Moparthi, and today I will be presenting on my research, the evaluation of the limitations of clinical efficacy and practicality of nasal alveolar molding device. This research was conducted by Dr. Hyma Moparthi and Dr. Joseph Cheever at the Roseman University College of Dental Medicine and Orthodontics. So cleft lip and palate affect approximately 1 in 700 live births worldwide. Beyond the immediate surgical needs, these conditions significantly impact feeding, speech, aesthetics, and the psychosocial well-being of the child. While surgical repair is the standard of care, the severity of the initial deformity can complicate surgical outcomes. This brings us to nasoalveolar molding, or NAM. NAM is a non-surgical, pre-surgical orthopedic technique. The therapy typically begins with the first 1 to 2 weeks of life to take advantage of the high plasticity of nasal cartilage in newborns. The goal is to shape the alveolar ridge, lip, and nasal cartilage before the primary surgery. By doing so, we aim to reduce the width of the cleft and improve the anatomical conditions of the surgeon. However, despite its popularity, questions remain regarding its overall trade-offs. Therefore, the objective of this study was to critically evaluate 3 specific areas: the clinical effectiveness, the practical feasibility, and the long-term outcomes of NAM therapy. So moving on to our methods, we conducted a structured literature search using engines such as PubMed and Google Scholar, covering the period starting from September 2025. We utilized specific keywords including nasoalveolar molding, pre-surgical orthopedics, effectiveness, long-term, and feasibility. Our inclusion criteria was strict. We looked at peer-reviewed English studies, including original research, systematic reviews, and meta-analysis that specifically addressed effectiveness, practicality, or long-term impact. We excluded case reports, conference abstracts, and interventions unrelated to NAM. From an initial identification of 27 studies, we screened for duplicates and relevance, ultimately resulting in 19 full-text studies for our final synthesis. This included a mix of systematic reviews, cohort studies, and retrospective reviews. So now let's discuss the results, starting with the clinical outcomes. First, regarding nasal and alveolar morphology. 15 of our included studies reported on this category. The consensus is positive. Most studies reported improved nasal symmetry, increased columnar length, improved nasal tip projection, and a reduction in the width of the alveolar cleft. However, it is important to note that the magnitude of these improvements varied significantly between studies. This is largely due to inconsistencies in measurement techniques, which ranged from using 2D photos to 3D imaging. Second, regarding the surgical outcomes, 10 studies address this. The literature indicates that NAM is associated with improved anatomical conditions at the time of primary repair, specifically reduced soft tissue tension. However, the data regarding secondary revisions is mixed. While some studies report fewer revisions needed later in life, others show no significant difference compared to non-NAM patients. And third, regarding aesthetics. 8 studies focused on this area. Generally, early post-operative improvements in lip-nose symmetry are reported. The limitation here is a lack of objective measures. Aesthetic definitions were inconsistent across the literature. While the immediate clinical results seem promising, our review highlighted significant limitations, particularly regarding long-term and functional outcomes. While we look at long-term outcomes, the evidence is limited. Crucially, the early morphological improvements achieved by NAM are not always maintained as the child grows. Long-term data is heavily influenced by subsequent surgeries and the natural growth of the patient, making it difficult to isolate the specific long-term benefit of the NAM device itself. Regarding functional outcomes such as speech, feeding, and nasal airway function, only 5 studies reported data. The reporting was inconsistent, and the direct association between NAM therapy and improved speech or feeding remains unclear. We also identified methodologic limitations across the board. Many studies suffered from small sample sizes, retrospective designs, and variable follow-up periods. Because NAM protocols vary by center, differing in appliance design and frequency of adjustments, it is very difficult to compare results across different studies. So finally, we must address the practicality and treatment burden, which is a key focus of our evaluation. In terms of complications, they are generally minor. 7 studies reported issues such as mucosal ulcerations, skin irritations from tape, or appliance dislodgement. These are usually manageable with adjustments. However, the treatment burden is significant. 6 studies highlighted that this therapy requires frequent visits, prolonged treatment times, and reliance on highly specialized care. Caregivers report a significant burden in terms of time, cost, and logistics. Furthermore, availability is an issue. NAM utilization varies by medical center and is influenced by provider training and socioeconomic factors. In conclusion, our evaluation suggests that while nasoalveolar molding is effective in improving immediate nasal and alveolar morphology and surgical conditions, its long-term benefits are less certain. The therapy demands a high level of commitment from caregivers and resources from the healthcare system. Therefore, while it is a valuable tool, clinicians must weigh the clear short-term morphological benefits against the significant treatment burden and the lack of robust long-term evidence when recommending this therapy to parents. Thank you for your time, and I hope you have a good day.